Now, the immunosuppressants in general can be somewhat overwhelming because, there's a lot of information, but I think of the immunosuppressants really, at least the high yield ones, into, two kind of separate categories. Okay, so we're going to do category 1 here. So category 1 is just about a pathway. Okay, it's a pretty straightforward pathway. There's only 4 or 5 steps to it. So going back to kind of the pathophys we've talked about before. So again, this is going to be an antigen presenting cell, and this is going to be a T cell. Okay, now we already said antigen presenting cells can present antigens, right, via MHC2 to the T cell receptors. Usually this will be a CD4 positive T cell, right? And so the antigen presenting cell binding here will then activate this T cell, right? So this T cell now has the matching antigen. This T cell receptor gets activated, right? It gets activated, and the process here involves this calcineurin. Okay, so calcineurin will help activate nuclear factor of activated T cells. Essentially what this thing does is it just increases the transcription of interleukin 2. That interleukin 2, remember we said when we talked about cytokines, interleukin 2 can, have paracrine effects at nearby cells. It can have endocrine effects at distant cells, and it can also have effects at that same T cell, right? Autocrine effects. And so the concept is, right, interleukin 2, remember, we're stimulating pretty much a lymphocyte response with interleukin 2. Everybody's going to have lymphocyte growth when I have interleukin 2 released. And this interleukin 2, like I said, can go back to this T cell for the simplicity of this diagram and bind to the interleukin 2 receptor, okay? And the interleukin 2 receptor, and we don't need to go into all the details on this, but this can eventually lead to activation of the mTOR kinase and mTOR. And again, like I said, we don't need to go into all the details, but essentially stimulating T cell growth. Okay, as well as growth of lymphocytes in general. But that's the bottom line. So the pathway started with the presenting of an antigen, right? So we presented an antigen, that's where we started, and we ended with some increase in T cell growth. Now, if you look at this, there's really 4 points that you want to be familiar with. Things aren't as bad as they may initially seem. All right, let's clear this up and talk about it. Okay, so the first one on here is the calcineurin inhibitors. Now, we already said this antigen presenting cell is going to bind to the T cell, right? It's going to do so via this MHC2 typically, and the calcineurin here is then going to be one of these mediators that's essentially going to act to increase interleukin 2 transcription. Now, if I inhibit calcineurin, right, if I inhibit this step, then I'm going to have a decrease in my interleukin 2 released. Therefore, right, I'm going to have less interleukin 2 binding to the receptors, less T cell growth. That's why these are immunosuppressants. They're essentially suppressing in this particular diagram, the response of T cells. But remember, interleukin 2 acts on B cells, natural killer cells, etc. Classic drugs here that you want to be familiar with. The first one is cyclosporine, right? Cyclosporine. And cyclosporine can bind to cyclophilin. Okay, so by binding to this molecule, it can help eliminate some of the calcineurin here, right? So it can inhibit it. The other one is tacrolimus, commonly see on the words as people just say tacro, right? So tacrolimus can also inhibit, but it binds to a different protein, FK506 BP, or binding protein. The point here is, you might be saying, do I have to know this? Well, sometimes they ask questions about these calcineurin inhibitors, which is what they're doing here, right? They're calcineurin inhibitors, and you sometimes have to know the protein they bind to. Okay, and I'll kind of explain how they tee this up in a second, but the point is, the bottom line is that at the end of the day, we're decreasing interleukin 2, right? Why are we decreasing it? Because we never really activate this nuclear factor of activated T cells to increase interleukin 2 transcription. Okay, so we're kind of blocking this pathway upstream here. And so for that reason, we have less interleukin 2 released. Now, when would you use this? Well, if you wanted to do some kind of immunosuppression, right? So immunosuppression being transplant rejection prophylaxis, preventing transplant rejection. You can also see it used in psoriasis. These are the big 2. Now, I want to say that, this is not an exhaustive list of immunosuppressants, and it's not an exhaustive list of indications or adverse effects. It's really just the high yield stuff, right? This is the big stuff that you want to know. The really important thing about calcineurin inhibitors, where this kind of gets paradoxical, is that they can cause nephrotoxicity and neurotoxicity, right? They can damage the kidney, they can damage the nerves. Now, the biggest thing is the nephrotoxicity, and the reason for that is because the mTOR inhibitors, which I'll talk about in a second, there is no nephrotoxicity with those. Okay, so this is where you have to distinguish these. What's really interesting is that a lot of times, when we're using these for transplant rejection prophylaxis, the calcineurin inhibitors actually are used for transplant rejection prophylaxis for patients that are getting renal transplants, right? When they're getting kidney transplants. You'll see these patients after they've gotten their kidney transplant, they're on cyclosporine, they're on tacro, and the thing is that they can actually cause nephrotoxicity because the cyclosporine inhibitors, or I should say the calcineurin inhibitors, can cause decreases in renal blood flow, leading to decreased perfusion of the kidney, right? That transplanted kidney, and that can cause direct endothelial damage to the kidney, right? AKI, CKD, etc. So there is a component of nephrotoxicity, and that's the particularly high yield side effect. Now, the way that you distinguish, you might be saying, okay, well, these two sound exactly the same. Am I going to have to distinguish the two? Well, if you did have to distinguish the two, it's important to know that only cyclosporine can cause the gingival hyperplasia and hirsutism, right? So cyclosporine in general, if you're in a board question and you're trying to distinguish cyclosporine from tacro, that's what you're looking for. When I see gingival hyperplasia, by the way, in a board question, I'm usually thinking about phenytoin, okay? So there's certain, unique side effects in board questions that you'll see from medications that really make you just kind of jump to something. So when I see gingival hyperplasia, I jump to phenytoin. If phenytoin is not related to the question, the next thing I'm thinking about is distinguishing cyclosporine from tacro. Okay, so that's what I would remember there, because again, they both have similar effects overall. Now, the way a board question can do that is they can give you a patient that has gingival hyperplasia and then ask you, what is this? Because again, not a lot of this is on management. It's more about mechanisms for step one. So they can say, yeah, this patient's got gingival hyperplasia, right? They're post-renal transplant. Maybe they have a little bump in their creatinine. And they say, well, what medication or what's the mechanism of action of the immunosuppressive medication this patient's on? And one option might be binding to cyclophilin. Another option might be binding to FK506, right? And so that's where you have to distinguish that. If they have gingival hyperplasia, it's binding cyclophilin, right? So all right, so that's calcineurin inhibitors. All right, we're going to jump kind of to the mTOR pathway. So we talked about calcineurin. Now let's talk about this mTOR. Again, after this interleukin-2 receptor is activated, right, there's going to be this mediator mTOR that's going to kind of assist with the growth. It's like the last step that we're going to focus on in this pathway. Now, the mTOR in general can be inhibited by sirolimus. Now, the difference with sirolimus, as you can imagine, because this is more downstream, right? This mTOR is more downstream. It shouldn't necessarily have the same effects on interleukin-2 that we talked about with the calcineurin inhibitors, right? Because it's downstream. We should still be able to make interleukin-2. It's just that the interleukin-2 receptor, after it gets activated, it's not really going to do too much, right? Because we're blocking downstream from that. Sirolimus can also bind to some of these FK binding proteins, similar to tacrolimus. So that's why you have some similarity in the name, but again, it's primarily going to be inhibiting mTOR. And again, classically used for renal transplant prophylaxis, and the high yield adverse effect here is pancytopenia. The important thing, the really important thing, is that there's no nephrotoxicity, right? So when we're using sirolimus, we're not usually talking about direct damage to the kidney, right? So that's going to be very different from the calcineurin inhibitor. So that's particularly high yield. One big thing to distinguish these two that you want to remember. Now, when we're talking about these last two drugs on here, we have one that's targeting the interleukin-2 receptor. So you can imagine, we just talked about blocking mTOR downstream. If you block the interleukin-2 receptor, right, you're essentially accomplishing the same task. You shouldn't really have any effects on interleukin-2, right, because this is all kind of before this step in the pathway. The problem is now interleukin-2 won't be able to bind the receptor because I stick this antibody on the receptor. And we've actually seen this before. If you remember in type 2 hypersensitivity reactions, we have cytotoxicity when we bind antibodies, right? When we talk about diseases like autoimmune hemolytic anemia, for example. But when you think about diseases like myasthenia gravis, right, where you have antibodies, anti-acetylcholine antibodies, for example, that bind to the acetylcholine receptor and essentially block it. Right? That's a receptor binding, type 2 hypersensitivity. That's what this antibody is doing, right? This basiliximab is binding essentially to the interleukin-2 receptor, and it's blocking interleukin-2 from binding to it. Okay, and so this is the chimeric version. The daclizumab is essentially the humanized version of it, but in both situations, they're blocking the interleukin-2 receptor. If I block this receptor, I don't actually get the effects of interleukin-2 in these T cells, right? I might be releasing some interleukin-2, but I'm not actually going to be able to stimulate the interleukin-2 receptor with interleukin-2 because I block it. Okay, so again, also transplant rejection prophylaxis. You can see hypertension and edema, kind of more nonspecific. The important thing here, remembering that this is a type 2 hypersensitivity reaction because we're blocking the receptor. Okay, the last one on here is recombinant interleukin-2. And I don't want to confuse you. Recombinant interleukin-2 is actually not an immunosuppressant. Okay, so it's not an immunosuppressant. So you might be saying, well, Dr. R, why would you include it on this slide if it's not an immunosuppressant? The reason I include it here is because it's just a really good place to see this whole mechanism and see where this drug acts. What does this drug do? So essentially, recombinant interleukin-2, it's interleukin-2, right? I'm giving this patient, essentially giving this patient interleukin-2. So let's just say that I give this patient interleukin 2. Okay, so I give them interleukin 2, which is this drug L-dysoleukin. And so what's interleukin 2 going to do? Well, we already know interleukin 2 is essentially going to bind to the interleukin 2 receptor, and it's going to activate it, and it's going to cause these T cells to grow. It's going to cause natural killer cells to grow. It's going to cause B cells to grow, right? We're going to activate lymphoid cells. And so that's what recombinant interleukin 2 is doing. So you can imagine this is the opposite of immunosuppressant. This is going to increase my immune response. Why would I want to give it? Well, again, if I have a patient that has malignancy, right? And we talked about this a little bit with graft versus tumor effect. We can have our lymphoid cells target those malignant cells by recognizing those cells on MHC1, right? We can recognize cells on MHC1 that have improper antigens or no antigens at all potentially and mark those cells for destruction. So if I have a more robust immune response, I'm better able to do that. This is particularly useful in renal cell carcinoma and metastatic melanoma. Distinguish this in the sense that this is not an immunosuppressant, but it does come up in these conversations where you have to kind of go through this mechanism because it's right in the middle of this mechanism that we're talking about. Now, the second kind of category of immunosuppressants are going to be the glucocorticoids and the purine inhibitors. Again, this is in my mind how I'm organizing these pathways. Let's start with glucocorticoids because I think we've talked about this quite a bit already. So glucocorticoids, we've already went through the NF-κB pathway. And again, the NF-κB pathway is really essential for kind of kicking off the inflammatory response. We're trying to get an inflammatory response that essentially generates, acute inflammatory reactants, things like interleukin 1, interleukin 6, and TNF, right? That's what we're trying to do with NF-κB. As it enters the nucleus here, impacts transcription potentially and causes an increase in transcription of interleukin 1, 6, and TNF. So that's what NF-κB is essentially doing. Now, glucocorticoids are trying to basically eliminate that process from happening. So they're going to inhibit NF-κB and the inflammatory cytokine genes. So a glucocorticoid, remember, we're talking about a steroid, so it can usually freely diffuse through the membrane here. It'll bind to a glucocorticoid receptor in the cytosol, essentially block off this NF-κB, essentially inhibit it. Okay, and so that's what you see here. The glucocorticoid bound to the glucocorticoid receptor, inhibiting NF-κB and the inflammatory cytokine genes. That's really the extent of what you have to know here, right? You just have to remember that's the primary mediator that we're inhibiting. And again, these can be used for a lot of different things. Adrenal insufficiency, we'll talk about this in the endocrinology section. Asthma, especially acute exacerbations, or even chronic maintenance therapy with inhalers, acute inflammatory states. The big thing you'll see glucocorticoids used when we're talking about transplant rejection is, like I said, when you have an acute rejection, okay, you can usually do high-dose glucocorticoids to try to eliminate that acute rejection from happening or at least damaging the graft any further. But glucocorticoids in general, you'll see in all different types of board questions. In terms of the adverse effects, we can make a really, really long list here, okay? So osteoporosis, Cushing's syndrome, hyperglycemia, amenorrhea, avascular necrosis of the femoral head, also very classic. And we'll go through this all in a lot greater detail in its respective video. I'm just including it here so that we can see this in completeness sake. Now, the two big things to remember, though, is when you give a patient glucocorticoids, you're going to essentially lead to a lot of those white blood cells, like we talked about with trolley, getting released into the bloodstream. Okay, so you're going to immediately see, some people call this an artificial leukocytosis. It's basically showing that a lot of those white blood cells that were sequestered in the pulmonary vasculature are going to get released systemically. Okay, so you're going to have an elevation in the white count. Especially when you go on the wards and that kind of thing, you see a patient, you see a big jump in their white count, or they have an elevated white count. The first question always should be, are they on steroids, right? The other thing is, if a patient's on glucocorticoids for a long time and you just suddenly take them off, well, you've been suppressing their ability to produce glucocorticoids for so long because you're giving them glucocorticoids, right? Everything wants to stay in some level of homeostasis. And when you have really high dose glucocorticoids being given over a long period of time and you suddenly take them away, now the patient is going from having potentially more glucocorticoids than they would normally have, right, based on homeostasis, right? But now you take that away, and now they're having way too little glucocorticoids, and you can send those patients into adrenal insufficiency, which is actually one of the most common causes of adrenal insufficiency. Again, we won't have to go through all the details on that. Big ones, though: prednisone, dexamethasone, methylprednisolone, right? We can make a long list here, but that's the concept for glucocorticoids. Again, we're just going high level here. Now, when we're talking about purine inhibitors, okay, so purine inhibitors, we're talking primarily about things like azathioprine and 6-mercaptopurine. So azathioprine and then 6-mercaptopurine are the big ones that I want you to remember. So essentially what's happening here is azathioprine goes on to form 6-mercaptopurine. 6-mercaptopurine actually can compete with some of the other purine derivatives like hypoxanthine, guanine, and by doing that, by competing with them, it'll actually inhibit some of your de novo purine synthesis, okay? And we'll go into this in more detail in the biochemistry. But the enzyme here is PRPP aminotransferase, right? This is the rate-limiting step. in de novo purine synthesis. Again, when I'm saying purine synthesis, I'm talking about the synthesis of the building blocks of DNA. That's what we're talking about. Now, if I inhibit that step, right, early on, I'm going to have a decrease in the number of purines being produced, right? If I'm using something that kind of looks like a reactant here, essentially, but isn't quite doing what it's supposed to do, right? It's not actually going to be a building block of DNA. That's going to kind of tie up this enzyme, right, and inhibit this process. And so I'm going to get less formation of IMP, which would be a downstream step, less guanine, less adenine essentially being formed, less nucleotides, less DNA production. Therefore, the cells that rely on high levels of nucleotides for very frequent replication, right, responding to pathogens, foreign invaders, generating a robust lymphocytic response, those cells, the lymphocytes, are going to be in a lot of trouble, right? When I give drugs like this and I block the formation of new purines, right, the synthesis of new purines and the formation of DNA, that's going to be a big problem, but it's going to be a big problem for the cells that have to replicate the most, right? If a person is fighting off an infection, these cells are going to be replicating. They're going to be going through, maturation affinity with the B cells. The B and T cells will need to generate a memory response. You're talking about things like affinity maturation with B cells. It's a lot of replication going on and a lot of transcription also going on. So when you start to take out any building block of DNA, you're going to feel the effects of it, particularly in the lymphocytes. And that's essentially what's happening here. Now, mycophenolate and then ribavirin, which I won't talk about too much here, these are both going to have a similar effect, but we're mostly going to be inhibiting the enzyme inositol monophosphate dehydrogenase, IMPDH here. And again, we'll go through the whole pathway when we talk about biochemistry. I don't want to get too off track, but essentially mycophenolate is going to act here. So it's primarily going to inhibit the formation of guanine, whereas the 6-mercaptopurine purine should be more of a global effect between the purines. And I want to say too, for both of these, you do see mycophenolate, in patients that have had renal transplants. But in general, I would say, especially azathioprine, 6-mercaptopurine, mycophenolate, you see these more with patients that have like autoimmune conditions like rheumatoid arthritis. And step one isn't really big on, management per se. But I would say overall, they're more classic for things like inflammatory disorder, more so than a transplant prophylaxis. Mycophenolate is probably the one that you do see sometimes with transplant prophylaxis, but just kind of keep that in mind. The other thing on here that I didn't really show in this pathway is methotrexate. So just remember methotrexate, and we'll go through this, like I said, in the biochemistry section. But methotrexate, that's represented here as MTX. So methotrexate is going to inhibit dihydrofolate reductase, okay? Kind of like trimethoprim, but it's going to do that in humans, right? So it's actually going to be used more as an immune suppressant agent because, again, if I'm inhibiting the building blocks of my DNA, right, that being the nucleotides in some way, there's going to be a global impact, particularly on the lymphocytes, which rely very heavily on DNA synthesis, right? And we can see that down here, inhibits dihydrofolate reductase. Again, if I'm inhibiting dihydrofolate reductase and I'm interrupting purine and pyrimidine synthesis in doing this, potentially, that's going to have an effect on ability to undergo DNA synthesis. Okay, so that's what methotrexate does. Now, remember, trimethoprim is essentially doing this in bacteria. Okay, so when we talk about like trimethoprim sulfamethoxazole, the trimethoprim component is inhibiting the same enzyme, but just in bacteria. So it's preventing bacterial DNA synthesis, right? So that's why it's an antibiotic. Methotrexate is doing this in humans. So that's curbing the immune response in humans, right, by inhibiting this enzyme, because now the person that's being treated with methotrexate, right, they can't mount a very robust immune response because they don't have the building blocks to do so. And like I said, we'll go through all the details of the pathway on this in the biochemistry section. All right, and again, high yield adverse effects. Pancytopenia is a big one. Again, this all has to do with the fact that we're in some ways inhibiting the production of the building blocks of DNA synthesis, of which these cells very heavily rely on. Now, one last thing on here, or two last things I want to talk about. The first one is when you give a patient allopurinol. So kind of remember what allopurinol does here. So allopurinol, remember, there's a purine salvage pathway, and we can also break down these purines, right? So guanine can get broken down by xanthine oxidase, okay, by xanthine oxidase to form xanthine. This xanthine can then get broken down again by the same enzyme to form uric acid, and then we can excrete this in the urine. Now, this can also happen with hypoxanthine, and again, I don't want to go into all the details per se in this video because the video will be quite long, but what we want to talk about here is, remember, this xanthine oxidase can get inhibited by allopurinol, okay? And the concept here is I don't want a whole bunch of uric acid around if I have a patient that has gout. Okay, so allopurinol is frequently used as a maintenance therapy to kind of control the uric acid levels. What you have to understand here is that this 6-mercaptopurine can essentially end up forming hypoxanthine, right, as we start to break it down. The concept here is that this 6-mercaptopurine is kind of, in some ways, looks like an analog to things like guanine or hypoxanthine. And so the 6-mercaptopurine, right, I'm just going to put 6-MP here, this also gets broken down by xanthine oxidase. If I'm inhibiting my xanthine oxidase, what do you think is going to happen to this 6-mercaptopurine level? It's going to go up. 6-mercaptopurine levels will go up if I can't break it down. And you might be saying, well, will guanine levels and hypoxanthine levels go up? Potentially, but a lot of this will probably go through the purine salvage pathway, okay? So they'll probably go through the purine salvage pathway and form IMP, okay? And again, we'll go through all of that in the biochem section. The point here is that you get this buildup of 6-mercaptopurine, which is not going to necessarily go to form IMP. Instead, it's going to build up to potentially toxic levels, right? And inhibit too much of your PRPP aminotransferase. So just remember, if you have a patient in a board question on allopurinol and they're getting 6-mercaptopurine, there can be some serious side effects to that. And there's a lot of different ways they can word that, but you just have to remember that these two are associated in that way, in the sense that 6-mercaptopurine is broken down by xanthine oxidase, much like hypoxanthine and guanine. Finally, the last thing on here, just remember mycophenolate being associated with invasive CMV infections. So this is, again, an opportunistic infection that would, kind of push you in the direction of mycophenolate. So just kind of keep that in mind.